good posture is going to start at the pelvis. So you always start at the pelvis and then you move up or down the kinematic chain. So if this is your first time here, my name is Lily. I'm a neurologic physical therapist and I create videos for physical therapists to master topics in neurologic physical therapy. And today we're going to be talking about pelvic obliquities. And so when you're, let's say, working with an individual who demonstrates abnormalities or postural abnormalities at the pelvis, there's many different types of like deformities that you can find, posterior pelvic tilt, an obliquity. You can find deformities at the spine like kyphosis or scoliosis causing a pelvic obliquity. And so when you are evaluating someone in the seated position, the first thing you need to look at is the pelvis. The pelvis is going to be key to start assessing the sitting position. And so there's going to be forces that are going to be influencing the sitting position. Do they have good trunk control? Do they have scoliosis? Do they have kyphosis that is causing a posterior pelvic tilt? So there's going to be different things that you have to assess, right? By no means I'm a wheelchair evaluation expert, but I understand the importance of the pelvis when I'm teaching my PT students. When we're talking about sitting balance and trunk control, you need to look at the pelvis first. So there's two types of pelvic deformities that, could be categorized into a symmetrical deformity, which could be a posterior pelvic tilt. The pelvis is tilted symmetrically. Both sides are, equal, because remember that pelvis can rotate, right? And then there's the asymmetrical, which is the pelvic obliquity, right? So this is when the pelvis, it is not aligned. There's a side that's lower and the other one is higher. And so there's different things, if we have pelvic obliquity or we have a lateral trunk lean or a posterior pelvic tilt, all of those can alter the distribution of forces, okay? Or the distribution of pressure on the skin. Okay, you need to be aware of this because this can result in an increased risk of skin breakdown, aka pressure points, aka pressure ulcers. Okay, so improper positioning is going to result in many, many different things, right? And the first thing you need to know today is that you can have fixed or you can have flexible deformities. Okay, so in this case, since we're going to talk about pelvic obliquities, you can have a fixed pelvic obliquity or you can have a flexible pelvic obliquity. Okay, so that's the first thing you need to know. When the abnormality is going to be flexible, okay, so here, let me actually move this so you can see. And I know that you love visuals, so I'm going to just type it in here. When it's flexible, it means you can correct it, okay? Oops, 2 words. It means you can correct it. You will be able to move the pelvis out of that posture and back to a neutral pelvis, okay? You can correct it. When we're talking about fixed, it means you might not be able to correct it, right? It's the opposite thing. But the primary need for when you have a fixed pelvic obliquity is that it's urgent that you even the pressure distribution ASAP, okay? Because there's going to be excessive pressure on that ischial tuberosity, okay? Fixed means that there is a deformity that you cannot fix because the patient is not able to come into a neutral position, okay? So you want to protect that because it can result in a wound, right? So the other goals for a fixed pelvic obliquity is that you want to accommodate for the abnormal posture and prevent that abnormality from progressing, okay? So here we're going to look at an image just to summarize it all. This is a pelvic obliquity, right? The ASISs are not aligned. And so pressure happens here. Okay? So there's two types, flexible and fixed. Got it. All right. So now that you know that, what do we do about it? Which is what this video is about. That way you can remember for the exam or for your practice. Look at this picture. Ooh, this one, okay, so this could be either a fixed or a flexible obliquity, right? We don't know, right? A fixed obliquity could be someone who, has a congenital disorder. Now that person is in their 50s, 60s, so they lived with this deformity, so it's very hard to fix, right? They've been sitting in that position for a long time, et cetera, et cetera. So let's say this one, you see this, and obviously where are the excess forces happening here? Okay. Obviously, we have some here, right? And it doesn't contrast. Here is an excess force, like if they're sitting, right? Maybe here, there's going to be an excess force. So there's always like 3 points of control that they're typically used. And here, oh my gosh, this is like literally sinking in. So obviously this cushion is not good, right? But we need to be aware of where are the excess forces. That way we can correct it, right? Okay, got it. So we went through that. Now let me go back to, okay, so let's say we're dealing with a flexible pelvic obliquity, which means that you can correct it. Maybe your patient post-stroke is just sitting in just a very unstable surface or like a wheelchair and you're using the wrong cushion, et cetera, et cetera. When you have a flexible pelvic obliquity, here's the rule, okay? You want to build it up on the low side, okay? So you're like this, right? You want to bring this down by putting something here. That way this pelvis can correct. Yay. Okay, so rule for the flexible pelvic obliquity, you build up, under, low, side. That way the pelvis can go from here, you put something here, and it can go, okay, great. Now we've corrected it. Okay, now this one, I didn't realize that this is a frontal view, but let's imagine this is a posterior view. Okay, this is a posterior view. I would want to emphasize. I just realized that this is an anterior view. But let's say we're looking at the pelvis from posterior view. Okay, this is a posterior view. Anyways, we're going to continue. Okay. I should have said that before, but we're just going to roll with it. Okay, so let's say you're looking at the posterior view. Okay, so posterior view. Okay, so let's say now you have, so flexible pelvic obliquity, you're built up under the low side. Under the low side, okay? So let's talk about fixed pelvic obliquity. Fixed, meaning that you need to accommodate the high side of the pelvis for it to be fully supported, offering a support. That way pressure can be redistributed between both ITs, ischial tuberosities. Now, if the fixed pelvic obliquity is not addressed, okay, is not addressed, there's going to be a lot of pressure at the lower ischial tuberosity. Okay, so we're clear on that, right? So for the fixed pelvic obliquity, like you can't move this pelvis, it's fixed. Then what do you need to do? You're going to build it up on the high side, and then you maybe can remove some of the low side. Okay, so it's going to look like this. Like this is an example from a past lecture. You're building up on the high side. Oh. Okay, it looks like they're putting like a little cushion. And you're kind of removing some of that surface in the low side to release some pressure. Okay? So remember, with the fixed pelvic obliquity, let's say caused by a scoliosis, this scoliosis cannot be corrected by the cushion. So you need to correct what's underneath them. Okay, so if it's fixed, you're going to build up the high side and cut down under the low side. Okay, and cut down under low side. Okay, so this was a fixed one. Okay. All right. So this is the video on pelvic obliquities, extra simplified. And on the next video, we're going to talk about more topics on wheelchairs. So be sure to, I don't know what's going on, but make sure to check that out. I'll see you in the next one.